So good morning. Thank you for being here today with us. Okay, so thank you for being here today. We're gonna talk a little bit about topographic wide field analysis and also about telehealth approaching glaucoma. So let's start with the definition of glaucoma. Glaucoma on the 21st century has the same definition that we have prior years ago. It's a progressive optic neuropathy characterized by a specific pattern of anatomical and behavioral changes. So what we should be looking is for evidence of arcuate-like defects. This is the RNFL distribution in the posterior pole. We already know this for a long time. So the only type of defects that we should have been looking for in glaucoma are defects that affect this type of RNFL distribution. We have a particular zone that it's very vulnerable to changes in the inferior quadrant of the disc and also in the superior quadrant. So this arcuate-like defects is what we are looking for on the superior part of the posterior pole or in the inferior part. There is no single exam to diagnose glaucoma. We need several studies, and that is time-consuming, and it's also resource-consuming. So the clinical paradigm for diagnosis of glaucoma includes visual field testing, OCT scans of the optic disc. But this is facing three challenges. The macular region is affected early in the glaucomatous process, so this paradigm can miss or underestimate this damage. The use of typical visual field and OCT metrics underestimate the degree of agreement between structural and functional damage. And also, since the resolution of the OCTs has improved and local glaucomatous damage can be visualized like never before, usually the clinicians don't have time to look at the OCT scans, all of them, and we only see the reports. So we need to integrate all this information on a single report or so to have to avoid the misdiagnosis of glaucoma. So talking a little bit about the macula and the optic discs, there is a study, this is taken from the study from Hood and Dr. Demorais in Columbia University. So the first column will show the thickness map of a single healthy individual. This is a single eye. This is the cross-sectional slice of the OCT. This is in the macula for the ganglion cell layer, the macula for the RNFL, and the RNFL at the disc. And this column is 128 control eyes. What this shows, there is a pattern that we have on normal eyes. The pattern of the ganglion cell layer on the macula, the pattern of the RNFL thickness layer on the disc, and also on the macula are the same on all the control eyes. So anything that will alter this pattern will be abnormal. That being said, there is a growing clinical evidence that early glaucomatous damage involves the macula. The anatomical basis of this damage can be studied by measuring the local thickness of the RNFL and the local thickness of the GCL layers on this macula. This macular damage is typical arcuate also, not only the one from the RNFL, but also the one located on the macula. And here we're talking about the macular vulnerability zone. This is a small region where a lot of RNFL fibers will go into the disc. So according to Donald Hood studies, the most of the inferior region of the macula projects to this macular vulnerability zone, which is most affected during the glaucomatous damage. So we're seeing this on this graph. Here is the more vulnerable zone on the macula. This is inside the macula. All these axons from all these ganglion cells will come into this small region of the inferior part of the disc. Also, outside the macula, the ganglion cells that are over here will take in their axons and go into this small region of the disc. The superior part of the macula is less vulnerable because it will go into the disc on all this temporal quadrant, having a lot of space to have all the fibers going in. But outside the macula is different. It's also outside the macula in the superior part, a more vulnerable zone. So when we see slides from ANFAS images like this, we could see the projections of these artifacts or the defects of the RNFL and the ganglion cell layers that goes in accordance to this study. So this is going to be a little bit interactive. So I'm going to ask a couple of poll questions for you to keep this pretty interesting. This is poll question number 1. What kind of defects shall we be looking on the OCT to aid on the diagnosis of glaucoma? A, defects on the RNFL thickness and distribution. B, defects on the GCL thickness and distribution. C, arcuate-like defects starting on the macula and progressing into the optic disc. A and B are true, or A, B, and C, all of the above are true. Okay, we have the answers here, all of the above, that is the correct answer. With this, we now know that we do have to scan the optic disc, RNFL thickness, and scan the macula. The classic approach for this is doing a 9x9 or 6x6 scan on the macula and another scan 6x6 on the optic disc. You'll have two separate scans. There is software right now from different brands of machines that could stitch this together, and then you'll have a bigger scan. Others are still working them separately. But right now, there's also wide scans and Widefield analysis. Widefield analysis will be a 9x12 scan like this one. You'll see 9 millimeters here and 12 here, and you'll get a big area of the posterior pole where you could measure not only the segmentations for the RNFL thickness and the GCL thickness that we're talking right now for glaucoma, but also for information about the macula. I mean, other type of pathologies of the macula. So this is how a normal view for a patient in a 12x9 wide topographic view looks. You'll have here the ANFAS image that is set at 52 microns. There is where the RNFL thickness are shown. This is the thickness of the RNFL. This is the topographic view of the 12x9. You will have here a big B scan of the circumpapillary RNFL circle scan. So you could look if there is any issue on the segmentation of this image that is showing an artifact and it's not according to what we are thinking. The other interesting part of this is that here we have this macula. Since we are having a lot of interest looking at the macula, we're having here the GCL thickness profile of the macula. This is typical. So remember the first slides when we talk about the typical assessment of the normal healthy macula and the normal healthy RNFL on the disc. This is how it looks like. Over here we have probability plots. This is a simulation of how this will be on a visual field testing. So if you had any type of abnormalities on the OCT, this will show on this simulation of this 24-2 down here 10-2 how it will show on the visual field testing. So this is normal. Now let's take a look about how it looks abnormally. Here you will see that in the ANFAS image, these arcuate-like defects that we were talking about. If we see the topographic view, you will see that the vulnerability zone affected in the superior quadrant, it's outside the macula, and the inferior quadrant, it's inside the macula. This is typically shown in glaucoma. Remember, these are the areas that are most affected. Superior outside the macula, inferior inside the macula. Then we have the classic defect of the ganglion cell layers, and it will show that the donut, typically donut seen in the ganglion cell layer, remember this one, this is normal, it has, someone has taken a bite from the donut. You see that there's something missing here. And this is the region of interest where the ganglion cell layers are affected. So in the visual field, this will show a defect, arcuate defect, superior and also inferior on the 24-2 and also on the 10-2, because the defect is central to the macula. Remember, on the visual field view, you'll have the image of the macula upside down. There is some anatomical variations that could have or mimic some types of glaucoma-like topographic view. For example, this patient has the vessels shift, the blood vessels shift a little bit peripherally. So when we measure this, you will see this defect shown here on the simulation of the probability map. But when we see the ANFAS image, there is no arcuate-like defect, nor on the RNFL topographic thickness. This looks like the normal characteristics. And here, the GCL classic donut also looks perfect. If we do see the metrics, we will suspect about this yellow point and this yellow point. These are the positions of the blood vessels that are a little bit shifted. So how do we know this? In this report, these red lines will show the position of the normal blood vessels. You will see here the shadow on the RNFL takes in account for blood vessels. It's a little bit shifted, it's a little bit moved. So when we compare this to the normative database, that's why they plot out these types of defects. But this is not a real defect. You will have to see the topographic view, it's normal, ANFAS image normal, RNFL thickness normal, and GCL distribution also normal. So this is not a real defect. This is what we call red disease because of the RNFL anatomy and blood vessel shift a little bit periphery. There are variations also on the foveal anatomy. There is an interesting paper written by Dr. Gus de Moraes showing the inter-individual variations in the foveal anatomy that shows some artifacts. This is what we have, normal macula without any type of artifacts. And this is what we call a defect of the macula. It could be macular atrophy. It could be due to GCL diminish in glaucoma patients, but also could be an artifact. And these artifacts aren't shown. Gus de Moraes described almost 12 different artifacts, depending on the position you take the acquisition. You see here is this horizontal B scan. If the horizontal B scan is a little bit tilt, it's a little bit shift. If the position of the head of the patient is a little bit changed, you will start seeing this type of artifacts on the macula, and these are due only to the position of the patient. So not always the defects that aren't shown on the OCT of the RNFL thickness are real, and not always what you see the defects on the macula are real. What we have to see is an accordance between all these types of exams to have a good interpretation of the results. So we are now coming to our poll question number 2. Those variations on the RNFL and foveal anatomy reflects a problem on the correct assessment of these structures? A, yes, they always affect the metrics and results, so-called red disease or green disease. B, sometimes they affect the metrics and the results, but this could be corrected. C, no, they never affect the metrics and the results. D, Only RNFL variations affect the metrics. Foveal variations are not important. Or E, RNFL and foveal anatomic variations always affect the metrics, but is the clinician interpretation of the topographic defects, which should be mandatory for the interpretation of the results. Okay, so we have the correct answer, 74%. The clinician should take the last opinion interpreting the results. Let's see some examples about this topographic analysis. This is the glaucoma patient with a classic 3D optic disc and 3D macula for GCL assessment. You will see the defects on the superior part of the disc. Here is starting this classical defect. We should know, remember for the position, that this defect could be outside the macula because of the more vulnerability zone. Apparently, the left eye doesn't show any type of defects. The metrics are all in green. I don't like that much the colors because we could mislead sometimes the diagnose. But let's say they are all within normal limits. And when we see the ganglion cell layer, since this is a bigger scan, this is a 9x9. The first one that we saw on the optic disc was a smaller one, 6x6. The 9x9 will show the defect we were pinpointing on the other slide, going outside the macula, but also having a small part of it inside the macular region. So that's why on the ganglion cell charts, we'll see this red or outside normal limits on the superior part. When we see the defect clearly, it shows where it is and the arcuate type of the defect. The other eye, it's normal. You will see a thickening with the blood vessels. This is the RNFL thickness, and also in the macular region seems that there is not much going on there. The issue is that we have to change between the one image optic disc and then macula to have the whole information. When we do have a Widefield 12x9, a bigger scan of this, we could see the entire defect coming into the optic disc. And also, this is the regular 9x9. This is the 6x6. When we stitch it together, like I told you, some machines does, we have this type of information. But even there, the scan size is not enough. What's going on outside these limits won't be taken in account. When we do a 12x9, we have a bigger scan. All this is taken in account. So we have even a bigger area of information. This is the report that shows us the defect again at the ANFAS images and also on the topographic view. When we see the defect of the ganglion cell layers, is pretty noticeable. And when we do see the simulation or RNFL probability and the visual field test, it shows a classic glaucoma defect. Also, when we go to the RNFL thickness plot, we could see that here is the part that is really being a lot of thinning in this part of in this area. This is the inferior part, and this is where the damage is. Let's see another example of another glaucoma patient. Again, you will see the GCL starts with a lot of defects. If you see the quadrants here on the thickness map, this numbers all the metrics because they are so big, they could be within normal limits. Here is a defect that we are looking for, and it's shown here. And if we see the macula is a lot affected, and this is the more vulnerability zone that we were talking about, again, on the topographic Widefield view, you will pinpoint clearly the defect. If we do the simulation, again, ANFAS image, pretty clear. Here again, topographic view, pretty clear. Here is the defect on the ganglion cell layers at the macular level. And this is the simulation where you could see the defects on the 10-2 and also on the 24-2. I've seen some questions popping up on the chat. I will address the questions at the end of the lecture. Don't think that I'm not looking at them. We will go there. But not everything is glaucoma. So sometimes we have OCT scans that look like this. This, if we just we start looking at the numbers, at the metrics, and at the colors, we'll see everything is on red here, and there is a defect here from the optic disc. Oh, that could be glaucoma. If we look at the macula looks so strange, so odd. This is not the classic donut view of the macula that we're used. We see a lot of defects here. When we saw the ANFAS view, something is popping up there. So let's take a closer look what's going there. What's going on there is that we have an epiretinal membrane. You could see all the flies that the epiretinal membrane is producing traction to this macular zone. On the B scan, it looks like this. You could see here this epiretinal membrane, and this is an alteration of this reports, an alteration of this topographic views due to another type of pathology. This patient could have a glaucoma, could be misdiagnosed. OCT won't give us a lot of information in this case. We do have visual field testings. Remember, this is a simulation. This is not a visual field testing. We should do visual field testing to compare and agree and have all the different tests and intraocular pressure and the clinical and the history of the patients are always mandatory. So remember that not everything is glaucoma. We have to look at the macula, not only for glaucoma, but for other important pathologies. And also, somebody has to be at the lower limits of the healthy controls. If we look at this patient, and if we look at the metrics, all are in red. Somehow, the donut shape, the topographic view of the GCL are normal. If we see here what's going on, we have some reds, and reds. But it do have the regular double hinge sign, it's thicker on the superior and in the inferior quadrant. And when you see here, looks like there is some RNFL missing, but if it's due to glaucoma, there should be something missing here, and there is nothing missing there. The probability maps show this. So what do we do in these cases? Is this normal? Is this a healthy control? Is this abnormal? Actually, this is a healthy patient that is in the lower limit of normality. So here, the topographic view of the macula is normal without anything wrong, a little bit less of RNFL thickness, but when we do on this patient, visual field test, it looks normal. Also, an important data is in these arrow points, where are the blood vessels located. When you have normal tissue, the blood vessels won't pop up. When you have less tissue there due to glaucoma, the blood vessels will pop up a little bit more. That's an interesting biomarker to look on the RNFL when you have these doubts. And as I told you, do a visual field test. We do think when we start doing OCTs that we won't be doing visual field testing no more, but that's not true. We're still doing visual field testing, and it's a functional testing. Remember, we will be doing this for a long time. So we do a visual field test of this patient, and it's within normal limits. Nothing there. It's the lower limit of the healthy controls. Remember to look all and everything should agree to diagnose the patient for glaucoma. The last example, it's a defect of head and eye torsion on the exam. Here we'll see normal, 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 and there's something here and something here that we don't know if it's normal or not. If we reposition the patient and scan again, look, it disappears. And if you see down here, the image just shift a little bit to the correct position. So the tilt of the head of the patient, the eye torsion, or anything like that could affect this. And we will have this type of artifacts in the exam. We do need to correct this. Since we are not prone to do the examinations and we just receive the reports, it's hard to know if when we receive the report, the patient is on the correct position. So we could rely on the software to do this for us, or we could correct this with post-processing afterwards based on the anatomical position of the vessels. That is the major sign of this type of distortion. Let's talk a little bit about glaucoma screening on the post-COVID-19. This is data from yesterday from the dashboard by the Center of System Science and Engineering from the Johns Hopkins University. We have over 2.5 million deaths and over 11, that's a lot of people. That's 114 people dead for COVID. So glaucoma screening is post-COVID-19. It's really interesting. It was a survey sent to the Glaucoma Research Foundation ambassadors, and that showed that only 3 or 4 respondents had a plan in place for reopening their office after stay-at-home orders were lifted. This was held on May 8, 2020. They have 3 questions in this survey. Question 1 is, are you still seeing patients in your office? Yes was the majority, but yes, but I'm only for emergencies is the second one. And this is interesting. Q2, are you able to offer telemedicine options for your patients? So yes, video and phone, like telehealth options, was 60%. Yes, phone only is only a little bit. So only a few people were prepared for this. How does this affect us as clinicians? How do we diagnose and follow up patients, chronic patients, with this? Home monitoring of IOP using self-tonometers is suboptimal, and it doesn't have the accuracy we would like it to have. Visual field testing and OCT requires a proper setting, cutting-edge technology to assure good reproducibility and limit inter-exam variations. Of that, home monitoring with this is not possible, although we have right now some OCTs that are portable and they're showing some promising results. Certain patients' queries can be handled by phone. For example, a red eye or some sort of conjunctivitis or a surgical treated patient if it has some worrisome, but it has its limitations for following patients with glaucoma. Sometimes clinicians have been reluctant to embrace telehealth for many reasons: patient safety, limits of the technology, training of the staff, conflicts of interest. There's a lot of different reasons. Innovative technologies can lead to improvements in care and decrease these disparities. So social distances in post-COVID era proves imaging machines are really valuable for managing chronic patients. Robotic OCTs and portable OCTs with multimodal imaging, including color fundus capabilities, make this task really possible. The functional visual assessment need to be tested too. There are some studies being made on that field. There are some augmented reality software that you could use on your iPhone or in your on your phone to have your eyes tested, but we need a lot more study in that part. So what it's coming really hot on this glaucoma screening, and not also glaucoma screening, but also a lot of different retinal pathologies, is artificial intelligence. So several IA techniques have been proposed to help detect glaucoma by analyzing of functional and structural evaluations of the eye. The use of artificial intelligence has also been explored to improve the reliability of prescribing this prognosis. So right now, we're having a lot of different studies on artificial intelligence. We have to know that there are different types of artificial intelligence. Uh, an iPhone with a Siri could be artificial intelligence. A Tesla self-driving car could be artificial intelligence. But we do have some more specific tasks. We're talking about machine learning and deep learning technologies. Deep learning has a lot of importance in medicine right now, and the specialty that has more deep learning studies and the more deep learning going on FDA approved clearance machines is ophthalmology. So these algorithms are managing a lot of data and helping us to often outperforming standards of global indices for expert observer. There remains no clearly defined gold standard for determining the presence and severity of glaucoma, which undermines the training of these algorithms, but we are going to be there. It's time for poll question number 3. Do you think artificial intelligence will play a role for managing the amount of image needed to review on the diagnosis of glaucoma? Yes, definitely. B, maybe at some point in the future, it needs more research and validation. C, I think I need more information about this. Artificial intelligence, a specific webinar will be nice. No, I think clinicians will still manage this information. E, I think it could help, but I'm concerned of the implications regarding patient data management outside a medical facility. Okay, we have several types of results. 1/3 think yes, 1/3 think maybe, and 1/3 think it could help, but I'm concerned about the implications. I agree with you guys. It's a little bit overwhelming what's going on with this, but I think it's the way we are going through. So, as we were looking, managing glaucoma involves many reports with dozens of parameters, plots, images, a challenge a lot of doctors are facing, and we have visual field tests, OCTs, we have color fundus photos, we have this new topographic reports, we have the older topographic reports, we have several OCT brands, and there is a lot of information that we are concerned. So if only there was an easy way to manage all this information. This is really a problem right now. The amount of information produced by OCT and visual field device can be overwhelming when evaluation patients on a really busy practice with glaucoma or in glaucoma suspect. Remember, we have to follow up all these patients also. So the needs, efficient and effective software solution to aid doctors in making quick diagnosis and the stage of glaucoma would be really helpful. Identify progression in these patients with therapy has been insufficient, and guide decision-making processes. So right now, what we are working is, and we're having a lot of interest in developing this, it's almost done. Actually, in some countries, it's available right now, is this glaucoma model. So in this glaucoma model, we are working with this topographic Widefield analysis. And what we do have is the major concerns that we have with the prior reports. The first one, how do we aid and avoid the head rotation or any sort of artifacts? The software taking account this, and we could assess the correct position of the blood vessels and have the correct positions of the scan to avoid all these types of misposition alignments, and that taking account so some types of errors during the diagnosis. We do have the same topographic view for the ganglion cell layer that it's really important at the macula. We have the simulation visual field testing points, but also right now we do have integration with a lot of different visual field test machines where we could import directly from the visual field test machine and have the real examination here. So not only the simulation based on the OCT, but also the real field testing where you could see the agreement with the simulation visual field testing points. This takes in account not only for one single view, but also for follow-up different patients. We could follow up the patients and then compare between topographic view, between ganglion cell layer view, between the color fundus and the visual field testing right now. So this is interactive. We could select different exams. We could flicker compare two exams. We could enlarge image. We have multimodal capacity. And this is driven, remember, by artificial intelligence that could help us find the correct positions of the vessels. There's a lot of information on these reports, and we do have a lot of the different tests that we have on just a single view that makes our lives really easy. This is how we could start repositioning the macula or the scan, the B scan, so we could flicker from this switch and place it in the correct position, as we're talking about, to avoid the different types of images that are not correct. This is the trend analysis view. We could trend analysis RNFL, GCL, the topographic views, IOP trend, and the visual field with the pattern deviation and the total deviation also. We could see a trend graph of every information that we have, or every test regarding the brand of the equipment that you're working to. So it's really, really very helpful. This is how the report looks like. You will have the correct image right now, and also the topographic views that we were talking about. So it's time for a last poll question. Do you think this OCT topographic approach to the diagnosis of glaucoma is better than the classic metric-derived diagnosis? Yes, I would like to start evaluating my patients with this method from now on. B, it's an interesting approach, but I would also use the metrics. C, I would consider evaluating my patients based on this method. D, no, I prefer using the metrics and the classic 3D scan reports because I'm more used to them. Or E, I would consider also the metrics from the optic disc parameters head, like a rim, capsule disc radio, and other parameters. Okay, so yes, 20%, it's an interesting, but have the metrics. 24%, I would consider. 16, no, I like that one, that you're thinking of more wide reports. I thought that a lot of people were used to the classic reports, and there's also a 40%. Most variety of the people think they need information about the optic disc head parameters. So it's really good to have all the information that we need in one place. I would like to have IOP testing. I would like to have topographic views. I would like to have corneal assessment to be sure that the thinning of the cornea on several other pathologies won't affect these measurements. The last thing that I will be looking through are the metrics, because metrics will and it's proven it will give us sometimes wrong diagnosis. I do look at the metrics to take an agreement of everything that I have been looking through, but it's not my primary concern about. So in conclusion, the integration of different diagnostic tools under a single user-friendly platform seems to be the logic approach to manage a lot of data in pathologies such as glaucoma. Science and technology are already present in daily life, clinical practice. These innovations offer significant improvement in patient flow, outcomes, and reduce healthcare disparities. It's when you're working with a single report and have all the information together, the workflow on your clinic, it really helps a lot. And right now, since we're not even we're having all these types of restrictions due to COVID, having this is really interesting. Artificial intelligence has the potential to revolutionize the screening, diagnosis, and classification of glaucoma, both through the automated processing of large data sets, as we've been seeing, and by early detection of new disease patients. So in addition, artificial intelligence holds promise for fundamentally changing research aimed at understanding the development, progression, and treatment of glaucoma by identifying novel risk factors and by evaluating the importance of existing ones. We thought a couple of years ago that this will be the future due to these restrictions due to COVID. Is now the present time. This is my last slide. I will This is my email if you want to reach me with any questions. And we do have some questions on the chat. I'll try to address as many as possible right now. So the first one, is thin cornea a risk factor for glaucoma? Yes, it is a risk factor. And for not for glaucoma, but you could have errors in the intraocular pressure taking. IOP could be a little bit wrong when you have a thinner or thicker corneas, and also it could affect the OCT scans. More the curvature than the thinning, but it's something that you should take in account. Glaucoma affect peripherally region or central regions. If you're talking about the visual field testing, glaucoma effects starts in the periphery and then finish on the center. If you're talking about the OCT, the macular vulnerability zone is the region where all start on the inferior part of the macula that takes in account the smaller region where all the fibers go into the optic disc. So it depends if it's on the visual field, peripheral. If it's on the OCT, it starts centrally. What is this blue color shows? I'm so sorry, I don't know what that blue color is. I couldn't answer that. How optic disc is affected in early stages of glaucoma? Well, optic disc is affected on early stages of glaucoma. The first thing that you should look on early stages of glaucoma, if you have an OCT, is the macula. If you don't have an OCT and you're just looking at the disc through a loop or you are doing an indirect ophthalmoscope, you have several biomarkers that you could look at the disc, like cup to disc ratio, like the vessels, how they're going, and if you have some vascularization on the disc. There's a clinical is always mandatory for this. What machine did you use for this hood analysis reports? Hood analysis reports are available in two machines. The Topcon one, both of them, spectral domain that's called Maestro 2, and also the SwepSource OCT that is called the Trident. And it's also available on the Heidelberg Spectralis machine, on the last version of it. Okay, which one is more important and meaningful in assessing cup to disc, vertical or horizontal? Well, cup to disc vertical is more important. What you see is that the more vulnerability, the macular vulnerability zone, they go in through the disc on the vertical axis. You will see diminishing of the cup to disc radio inferior early glaucoma, then superior, and definitely vertically is the axis that you should be looking through. What is the relation between IOP and optic disc in regard with glaucoma severity? Well, IOP, it's always one of the paradigms of glaucoma. IOP that leads into the optic disc damaging, right? So it's a relation, but remember that it's also normal tension glaucoma. So it depends actually on several anatomic features of the disc. What is use of number on matrix? Matrix, you're talking about FDT technology. I don't think you're talking about that. Well, FDT technology, double frequency technology, it's a good way to test the visual field. It will be, you could have visual field defects earlier than on a regular wide-to-wide 24-2. We use that on the clinic I'm working with right now. We still use that. So I think double frequency technology also had an importance right now. In case 3, is the scan not decenter with blood vessels sliding away from the reference? I think scan 3 was exactly the example of that. Which topographer is best for glaucoma? Field and wide field examination. We're talking about tomographers here. This is OCT's tomographers. We do have topographers for the disc. These topographers are not being used that much right now. We do prefer using OCT because OCT will give us direct measurement of the areas of interest, while the topographers will show the difference between a reference plane and the elevation with that plane. We used it. There is some people that use them a lot, but I sincerely prefer working with OCTs. I want to know when a young patient have 0.4 and point copy both eyes with refractive error. I think I will respond this. I'll type my answer because it's a clinical case for Samina. Have you tested cyberside artificial intelligence service for glaucoma? No, I haven't. Sorry for that. I will do that right now. Is there a diagnosis of glaucoma suspect? Is there a diagnosis of glaucoma suspect, or is it a term not using glaucoma investigation at management? Glaucoma suspect, yeah, it depends actually on how many tools do you have available. If you had a lot of tools, you should always go and look for the correct terminology and try to find the answer. Glaucoma suspect, if you have a patient that had intraocular pressure elevation and it has history of family history of glaucoma, yeah, he or she is a glaucoma suspect. But there you have to do the test, and when you do all the tests that you have available, you should arrive to diagnose. And even though you have some sort of doubts, then you could always ask the patient to come for a second visit, retest the patient, and see if there are any changes before the baseline and the second exam. Well, it's if 24-2 is full, but OCT shows some loss of RNFL, how often will your ideal repeat test to show perimetric progression to diagnose glaucoma? Like every 2 months or 4 months or 6 months? Okay, so if 24-2 is okay, but OCT shows some loss, and you are certain that the OCT image is well taken, then I will agree with the OCT and start treatment on that patient. How often do I repeat? Every 6 months or every year. If the patient is well controlled, every year is enough. If the patient is the first time you're looking for, or do you have any type of doubt, as we were spoken before, every 6 months will be nice. Are there studies that have shown the specific of wide field analysis in very early glaucoma? Yes, they are. Dr. Donald Hood and Dr. Gustavo de Moraes, they're having a lot of work done on this and on this field, and there are about 10 to 15 papers that were presented in ARBO last year. I mean, the 2019, 2020 was suspended due to COVID, and there is a lot of more studies that will be shown on ARBO this year. So if you're interested in that, in this, there will be a lot of new studies coming out soon. How do you find MRF field test, which is an online test compared to Humphrey perimetry? I'm sorry, Kishore, I never used the MRF field test, so I couldn't answer that. Please explain the 2 visual field reports on the Hood report. There are visual field simulations. What you're looking are the same points that are tested on the 24-2, that's the big superior one, and on the 10-2, that's the inferior one. So what we are looking are how the structural changes on the macula or on the disc affect the localization of these points. So due to this thinning of these areas, if you have inferior thinning on some part, you will have the same correlation on the visual field test. Are there any reasons why inferior arcuate of macula is more prone to be damaged in glaucoma compared to superior arcuate? Yes, there is. Let me show you. I think if we go back here, it will be easier to understand that. So anatomically, all the ganglion cell layers that are here will go into the disc, in the inferior part of the disc, but not the whole quadrant. You see, it's less than a third of the quadrant that takes in account for all this area. All these ganglion cells will be like trying to go into Tokyo Metro in rush hour or New York City Metro in rush hour. You see, there's a lot of people going through small entrance. That's what you're seeing here. A lot of fibers going through a really small entrance. If you see the superior part of the macula is less vulnerable because all this area will go into the temporal quadrant. That's the papillomacular bundle, a lot of this here, and the superior arcuate part that comes here. Being said that, there is a more vulnerable zone outside the macula on the superior quadrant due to the same effect. A lot of fibers coming through a very thin space. That's why here for the inside macula, inferior here for the outside macula, and superior here for the outside macula are the more vulnerability zones. Is visual VEP, I'm sorry, it's helpful for early diagnosis? I know that answer. What is VEP? I'm so sorry about that. Can VGF be related to glaucoma? Haven't read anything about that, but it's a really interesting question. I'll try to look at that and be back with an answer for you. I really don't know right now. What meaning -2 in 32? Oh, okay. What's the meaning of 2 on 32 and 24-2 and 10-2? The number of times they spot on the points on the locations that you have. 30 stands for the 30 degrees, 24 is 22, 24 degrees, 10 is 10 degrees, and 2 stands for the number of points that are being tested. Please guide about the disc. I'm sorry. The disc scan, the disc B scan on TopCon. Please guide about the disc B scan on TopCon. I'm so sorry, I don't know. What do you mean? I could type the answer if you explain a little bit more to me. That, thank you. Miguel, he's a little good to be here. I recommend to say the same doctor who realized the tomographies considering the artifacts. Well, yeah, the same doctor, the same technician. If that's not possible, be sure to train them as best as possible and make sure that they are aware of this type of defects. And sometimes if you are experimental reader, you could look at the defects on the reports or on the exams. It's always good to have a review station where you could go through all the B scans. If that's not possible, you could spot some of the defects on the scans, but it's more advisable to have the doctors or the people taking exams to be really good on this and spot this type of abnormalities. So normal IOP meant there is no glaucoma? No, there is normalization of glaucoma. Considering glaucoma diagnosis, which of the reports should we give more attention to between hood report and visual field, especially when there are different between them? You have to look at both of them. You have to look at the visual field, you have to look at the hood report, you have to look at all the history and all the data that you have to the patient. You have to look at all the information that you have, and the more information that you have, the more sure you'll be with your diagnosis. The hood reports help us a lot to have a lot of different information in just one single view report. When you are really used to look at it, it will help a lot. But I do always look at the metrics, the other reports, the optic test, and the visual field test. Which test is more reliable to come for glaucoma, visual field test or OCT findings? Oh, okay. So there is pre-perimetric glaucoma, where you won't see any defect on the visual field. There you could see defects on the OCT. If it's more advanced glaucoma, we do prefer to follow up patients with visual field testing instead of OCT, due to the floor effect. When the RNFL reached a level that is so low, then we couldn't use that to follow up patients. We could use the macula. So take home idea. Look at the macula on early glaucoma and look at the macula on advanced glaucoma. That will help a lot. But always look at visual defects too. Thank you very much. Okay. Thank you for attending. Maximum attend webinar nature. Great thing. Oh, thank you very much. Kindly gave us a few points for ganglion charts of OCT. How should consider while managing a patient? Okay, that will take a little bit more. I think we have 3 more minutes. I could type the answer to you, Samina. Thank you very much for your question. Are we going to get visual field indices on the HUD report? Yes, we're going to get that soon. We're working on that, hopefully real soon. Which test is more reliable to identify glaucoma? That's a hard one. I mean, I think, again, the more tests that you have, the more information that you get, the better you will get to diagnose this. But that's not always necessary. There are clinicians, always clinical findings are mandatory. Always start, these are diagnostic aids, but you should start with a clear suspect of this. So which is more reliable? Hard to say. I will rely all of them is if you do it yourself or you rely on the person who do that. For glaucoma diagnosed, optic nerve along with macula monomap is required. You could do it on a 12:9 wide scan or a single. Either way with work. If you do it 2 separate ways, you have more work to do. If you have the single view, it will make your life a little bit easier. When you have a lot of patients, that always it's helpful. Relationship of corneal thickness is important. Yes, we already addressed that. Can an answer be done instead of 10-2? You're looking for different type of pathologies. Ampler will help you with macular pathology, but not will help you with glaucoma. What about there is an issue of narrow angle? In this case, we're unable to view the macula and undilated pupil. That's right. If you have narrow angle, well, if you have narrow angle and you are, you could do several other examinations. You could do gonioscopy to assess that. You could do, if you have anterior segment OCT or UVM. If you don't have that, you could use a 90 diopter lens to assess just the disc. Or if you have non-mid cameras, you could have non-mid cameras with artificial intelligence aid right now. So you could take a picture and then you could send the picture to the software, and the software will do the reading for you. There's a lot of ways to do that. Thank you. Thank you. I think we finished with the questions right now. Thank you very much for being here. And it was my pleasure again to be with you. Thank you for your attendance.